I wrote this lecture when a strapped-for-time colleague asked me to provide a simple rundown of neuromuscular monitoring. These are the sources I recommend you consult on this topic. Many of you will know that the story of neuromuscular blocking drugs starts in South America, where curare was first used as a weapon. We don't use that drug anymore, but we still do speak of residual curarization, a phenomenon which remains disturbingly common. As for why it is still so common, who knows? Maybe it's because we manage to stay out of trouble most of the time, but maybe it's also because we don't understand neuromuscular monitoring as well as we should. Therefore, we are going to discuss the various methods of neuromuscular monitoring and their clinical applications. Our discussions will mostly pertain to non-depolarizing drugs because these are generally the ones that we are needing to monitor. There are two ways to measure neuromuscular function. One, you can gamble, or two, you can stimulate the nerve and measure the response either with your hand or with a machine. Of the machine assessment modalities, we will be discussing accelerometry because that is the method that sees the most clinical use. Acceleromyography is where a negative electrode is applied onto the skin overlying the nerve, such as the ulnar nerve just proximal to the wrist crease. The positive electrode is applied away from the muscle in question, and in the case of the ulnar nerve, this means putting it several centimeters proximal to the negative electrode. As they say, red to the head. The accelerometer is applied to a part of the body that moves as a result of muscle contraction. In the case of the ulnar nerve, the whole hand except the thenar eminence contracts, and this includes adductor pollicis, the big fleshy muscle between the thumb and the index finger. We place the accelerometer on the thumb and watch it jump. We apply a supramaximal current, usually 60 to 80 milliamps, which is established by prior calibration. It must be supramaximal so that we don't produce a falsely weak contraction that might occur if we didn't stimulate all the motor units. In general, more forceful contraction means greater acceleration, which means a greater potential difference transduced by the device. The most common muscle to test is the adductor pollicis, but we can also test orbicularis oculi, extensor hallucis longus, and I suppose any other area where you can get it to work. Where we place the device does matter, because not all muscles are created equal. Central muscles have more blood flow, resulting in faster delivery of drug, and then faster removal of drug from the site of action. This is the case for the larynx and the diaphragm, and it is the case for orbicularis oculi. However, in the diaphragm and laryngeal muscles, there are also more acetylcholine vesicles and acetylcholine receptors per junction, resulting in these muscles being intrinsically resistant to neuromuscular blockade. This is not the case for orbicularis oculi. This is reflected in the curve showing depth of blockade versus time. For laryngeal muscles and diaphragm, onset is faster, peak effect is earlier, maximum blockade is less deep, and recovery is faster. Have a think about what this might mean. I think it reflects the fact that throughout history, many animals have died as a result of paralyzing toxins, and we are the descendants of those who managed to achieve apneic oxygenation. Examiners have in the past asked how we should monitor neuromuscular blockade and where. These are the answers I have come up with from first principles. I don't have any evidence that these are the most correct answers. Nonetheless, at induction, it would make sense to use orbicularis oculi because, we would be able to intubate sooner with confidence. As it is, many of us will intubate before the patient gets down to one twitch of adductopolysis, knowing that the larynx is probably way ahead. During emergence, it would make sense to use adductopolysis for testing, because it would provide a higher degree of confidence that recovery has occurred at both the laryngeal muscles and also at the muscles necessary for coughing and deep inspiration. During neurosurgery operations, where movement absolutely must not occur, I would reason that it is best to monitor orbicularis oculi because the rate of recovery is similar to that of the diaphragm and the larynx. But in practice, what we might do is maintain a profound level of blockade that we monitor using the post-tetanic count on adductopolysis. This is a summary of the testing modalities used in accelerometry. This is a table that might be worth committing to memory. This is another table that you ought to commit to memory for the exam. I encourage you to pause the video to review this diagram. Note that no reduction in single twitch height occurs until receptor occupancy is over 70%. This reflects the extraordinary redundancy present at the neuromuscular junction. Note also that when all guns are blazing at 200 Hz of tetany, we are able to discern much finer degrees of neuromuscular blockade. Single twitch testing is employed in research settings. It involves simply one stimulus lasting 0.2 milliseconds. Calibration must be performed beforehand for the result to be interpreted. For non-depolarizing neuromuscular blocking drugs, it is not as sensitive a tool as the other methods. Double burst stimulation is where two lots of 3 twitches are delivered 3/4 of a second apart. Within each burst, there are 3 stimuli, each lasting 0.2 milliseconds and delivered at 50 Hz within the burst. There are only 0.18 milliseconds between each individual twitch within a burst, and this is not long enough for the muscle to settle down. Therefore, what double burst stimulation feels like is 2 very brief periods of tetany, 3/4 of a second apart. The double burst stimulation ratio refers to the magnitude of the second burst compared to the magnitude of the first. The DBS ratio and the TOF ratio are about the same thing in terms of their interpretation. They are also about the same with respect to machine accuracy. However, the double burst stimulation ratio is much better than the train of 4 ratio when it comes to manual accuracy, and this is where this modality is most useful. When we say that the double burst stimulation ratio feels normal, the actual ratio will be anything from 0.7 up to 1. For the train of 4 ratio, on the other hand, when we say it feels normal, for all we know it could be as low as 0.4. The reason the double burst stimulus is more accurate than the train of 4 ratio by manual assessment is that there are more twitches, that is, 6 rather than 4. This results in exaggerated fade, which is easier for us to discern. The train of 4 is the modality that we are all familiar with. 4 lots of 0.2 millisecond stimuli about half a second apart from each other. We measure the number of twitches, and if there are 4 twitches, then we also measure the ratio of the height of the 4th twitch in comparison with the first. It's worth pointing out that it is important to calibrate the machine for each patient before we administer relaxant. The reason for this is that under normal circumstances, each twitch can be a little bit bigger than the last due to potentiation. In fact, a normal train of 4 ratio can be up to 1.3. We saw on the diagram earlier that tetany is a very sensitive means of measuring blockade, but it is not without its problems. Firstly, it interferes with the train of 4 count for the following 6 minutes. Secondly, it is very painful. And thirdly, it requires mechanomyography for quantitative assessment. This is a technique where the thumb and forefinger are applied against an immobile strain gauge that measures the force of contraction. The post-tetanic count, however, does have a place in procedures where we must guarantee that there will be no movement. This involves a 5-second period of tetany, followed by a few seconds of rest, followed by 1 twitch per second until the twitches become imperceptible. At a count of 9, we tend to see the return of the first twitch in trainer 4 monitoring. At a count of 5, it will take about 10 minutes for the first trainer 4 twitch to return. At a PTC of 2, it will take about 20 minutes for the first trainer 4 twitch to return. I want to briefly mention the clinical tests of neuromuscular function, but only to say that they are not to be recommended. You may see some of these tests performed at the bedside prior to extubation in place of formal testing. Note that it is possible to perform a sustained head lift with a trainer 4 ratio of only 0.5. All the discussions we have had so far pertain to non-depolarizing blockade. It is possible to monitor the depth of depolarizing blockade using accelerometry so long as we use a pre-calibrated single twitch. Of the AMG techniques, it's the only one that is of any potential use. In practice, we hardly ever do this, of course, and that's because recovery from depolarizing blockade either takes 10 minutes, or it takes 30 minutes, or it takes forever. If, after ECT, there's crickets, then you've got your answer even before you find a twitcher. I understand that EMG can also be used to monitor depolarizing blockade. Finally, we are going to cover a few things which are frequently asked about in exams in relation to neuromuscular monitoring. Fade is a phenomenon observed with non-depolarizing blockade, where each twitch is shallower than the last because the neuromuscular junction is getting tired. The most accepted explanation for fade is that blockade of presynaptic alpha-3 beta-2 receptors prevents positive feedback on acetylcholine release. This does not occur with depolarizing blockade. Post-tetanic potentiation is the situation where there is an exaggeration in twitch height following a period of tetanic stimulation. This means that after performing a post-tetanic count, we should hold off conducting a trainer 4 testing for 7 minutes. The reason this occurs is there is lots of stimulation resulting in lots of activation of the presynaptic calcium channel. There is less time for calcium extrusion between nerve action potentials because stimulation is so frequent. Therefore, calcium makes it further up into the cell from where extra acetylcholine stores are mobilized. Phase 2 blockade is a phenomenon seen with large doses of succinylmethonium or repeated doses. There are several postulated mechanisms. The one that seems the most accepted at the present time is post-junctional receptor desensitization. According to this theory, continuous agonist binding results in large ion flux, which results in phosphorylation of a tyrosine unit, causing conformational change in the receptor, such that there is dysfunction of both the receptor and membrane, and such that there is flux between the resting and desensitized state, but not a return to the active state. Other theories include presynaptic receptor blockade and increased activation of the sodium-potassium ATPase as a result of depolarization. The only other thing to note regarding phase 2 blockade is that, although the table from before might suggest that neostigmine is a remedy, the response to acetylcholinesterase inhibitors is variable, and so it is preferable to wait for spontaneous recovery. Lastly, I want to mention a perennially confusing topic, the ED95. we might expect that it refers to the dose that produces a particular response in relation to neuromuscular blockade in 95% of the population. Instead, it refers to the dose that produces 95% depression of single twitch height in 50% of the population. The reason this term came about relates to the way dose-finding studies for muscle relaxants are performed. The subject is administered a little bit of relaxant, and then a bit more, and then a bit more, and after each dose, twitch height is measured. The same was done for all the other subjects, and the results are plotted on a graph like this one. You will recall that the ED95 is the dose that causes 95% reduction in twitch height in 50% of the population, and that corresponds here to 0.04 milligrams per kilogram. That is all. Thank you for listening.